Revered and respected by our ancestors for thousands of years, demonized and suppressed by the war on drugs, and now at the dawn of a new millennia, they are making their triumphant return. Scientists, researchers, and patients alike are exploring these ancient therapies to heal modern ailments. And we're here to bring you the latest in scientific research, cutting-edge practices, and first-hand experiences from those who have been transformed in body, mind, and spirit by plant medicines from cannabis to psilocybin to ayahuasca and beyond. This is the Plant Medicine Podcast.
Hello and welcome to the next episode of the Plant Medicine Podcast. I'm your guide on this journey, Dr. Lynn Marie Morsky, and today we are speaking with Dr. Josh Woolley about the differences between Psilocin and Psilocybin. Dr. Josh Woolley is an associate professor in residence in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco, as well as a staff psychiatrist in mental health at the San Francisco Veterans Affairs Medical Center. He is board certified in psychiatry by the American Board of Psychiatry and Neurology. He is the director of the Bonding and Attunement in Neuropsychiatric Disorders Lab at UCSF that focuses on understanding and treating social deficits in neuropsychiatric disorders, including schizophrenia, substance use disorders, and mood disorders. He is also the director of the Translational Psychedelic Research Program at UCSF, which brings together scientists and care providers across disciplines to understand how psilocybin, LSD, ketamine, MDMA, and related compounds impact the brain and other organ systems. If you are like me and have wondered, what's this psilocin thing we occasionally see popping up and how is it different from psilocybin and how might that be useful in a clinical setting or how might it apply to you as a person wishing to take a psychedelic medicine, you've come to the right place for the information. But before we get to Dr. Woolley, just wanted to share with you that this is actually the last episode of the Plant Medicine Podcast with the name The Plant Medicine Podcast. Do not worry, we are not going anywhere. But when I named the podcast initially, I wanted something that encompassed both psychedelics and cannabis and kratom. And really, it seemed like plant medicine was kind of the best way to encompass all of those things. But over the years, I have learned a lot, as hopefully many of you have learned from the podcast. But one of the things I've learned about is psychedelic exceptionalism, where we put certain drugs above others because we've decided, oh, these have a medicinal use, and then we continue to demonize others. And I think if you've been paying attention to what's been going on, the drug war is not working. The drugs have won the drug war. It was essentially a war on people of color and people from lower socioeconomic stati, and essentially it seems to me that plant medicine is a way that we've kind of euphemized some of these drugs to make it sound more palatable and less like, oh, other bad drugs as we decided is bad, heroin or crack or whatever. And that just causes a further divide that is not useful for the healing we all want to have collectively. And also, the word plant medicine or the phrase plant medicine is a little bit confusing. Some people think it means like veganism. And very often people say I have the plant-based medicine podcast, and that's definitely not what it is. So I have decided to rename it, keep the name in suspense for one more episode, because this is episode 99 of the Plant Medicine Podcast, but it is the final one, so stay tuned for some changes. Also, just so you know, those changes will come in the next year, in 2022. We're going to take a little 3-week break to ramp up everything, change the graphics and all of that. But feel free to go back through the last 99 episodes if you'd like to learn more about psychedelics. Now, just a reminder that if you are a clinician or if somebody you know and would like to share this podcast with is a clinician and you'd like to continue to learn more about psychedelic medicines and how they may be advantageous to your patients, please join us over at the Psychedelic Medicine Association. It is our mission there to educate clinicians of all backgrounds, physicians, nurse practitioners, therapists, acupuncturists, anybody to whom a patient may go with their concerns. We want to educate all of those frontline healthcare providers on the psychedelic therapeutics that can help their patients. So again, that is psychedelicmedicineassociation.org. Come on over, join us. We would love to have you. Now, without further ado, thanks so much for joining us today, Josh.
Well, it's my pleasure to be here.
I am excited to have this conversation because this is a question that I myself have had many times, because as we're hearing different things about psilocybin research and how it's processed, I'm like, what is this psilocin? how is it different? What kinds of things does it do? How does it interact with our physiology? And so I'm very excited that you're going to come on and hopefully elucidate that field of fungal wisdom for us.
I'll do my best. Do my best.
Excellent. That's all we ask.
Hmm.
We'll take most of your best. I'm just stoked to have you on here because this is actually an area of expertise that you are currently investigating. So if you could tell us just a little bit about the trial that, frankly, sparked me to have you on and ask this question. Love to hear a little bit about it.
Sure. Well, so I'm an associate professor at UCSF in San Francisco, and I'm the director of TRIPPER, which is the Translational Psychedelic Research Program. Uh, and
Nicely done.
yeah, you got to have a good acronym. That's critical for these things.
Right.
And so at TRIPPER, we are a group of multidisciplinary researchers across multiple branches of medicine. We have people who are internal medicine, psychiatry. I'm a psychiatrist, as well as neurology and pain specialists, and as well as clinical psychologists and neuroscientists, and a whole bunch of different expertises that we're bringing together to try and understand and move the field forward of psychedelic treatments for neuropsychiatric disorders. So, as a psychiatrist, of course, I care a lot about mental health. But we at Tripper, we also are very interested in pushing beyond mental health into other domains. So, for example, we're doing a study that we're going to dose next week, in which we're studying the effects of psilocybin on mood symptoms in people with Parkinson's. So very
Ooh,
exciting.
wow.
Yeah, so we're really hopeful. As you may or may not know, people with Parkinson's have a lot of depression and anxiety. Both before they know they have Parkinson's, as well as once they've been diagnosed with Parkinson's. So it's both
Oh,
the illness seems to affect the brain circuits that cause depression, but also having Parkinson's is pretty stressful.
I can imagine.
And the treatments are not great. And we're hoping that psilocybin in particular can help people with their, cope with their chronic illness that we don't have a disease modifying treatment for, as well as help their depression go down. So we're doing that, and that's an example of the kind of thing that we are excited about at Tripper, where it's mood symptoms, but it's a sort of a more complex neurologic disorder, and trying to really move the field forward. But the reason you have me on today is about Psilocin, and so we just got FDA approval to do a trial with naturally sourced psychedelics. So these
Okay.
are compounds that a company named Filament Health is extracting from actual mushrooms,
Wow.
which is interesting.
Yes.
Um, and so the trial that we're doing is oral psilocybin, but again, naturally sourced, consistent. So we know exactly how much psilocybin it is, versus oral psilocin. And psilocin is the active metabolite of psilocybin. So when you take psilocybin, you eat it, eat the mushroom or take a pill, it goes in your gut and it gets dephosphorylated into psilocin. And it's the blood levels of psilocin that predict your subjective experiences. So how high you get basically is dependent
Gotcha.
on your blood levels of psilocin. And for a long time, when you make it synthetically, for reasons that I don't totally understand, psilocin wasn't stable. So if you made psilocin synthetically, you would then turn it into psilocybin so it would be stable, and then people would take it and it would get turned back into psilocin. Um, Filament has figured out a way. I don't know how they do it to to get a stable psilocin that people can take as a pill. And so the first study we're doing is in healthy people. So not, as a psychiatrist, we do studies with depression and Parkinson's, as I was saying, but these are people without clear neuropsychiatric disorder. And we're going to compare, we're going to see, like, is taking a similar dose of oral psilocin similar to taking psilocybin? And when I say similar, like, we're looking at a couple of different domains. So how high people get, the time course of the high, is it similar or different? Side effects, do people have fewer GI side effects, for example? Cardiovascular effects, psilocybin makes their blood pressure and heart rate goes up. We expect psilocin to do that too, but that'll give us a nice time course to see, like, how does it compare? Also, how consistent. We're going to begin to get at that because it turns out there's some interperson variability in what blood level of psilocin you get when you take oral psilocybin.
Oh, interesting. Due to
Yeah.
the metabolism of
Yeah,
each person?
yeah. So different people have different metabolism. We don't totally understand it, but there is a fair amount of variability. Some people will have higher levels, some other people have lower levels, and this is obvious, right? When a bunch of people get together and use mushrooms, they can use the same amount of mushroom, and some people get really high, some people just get less high. Um, so we're hoping that oral psilocin, because it doesn't need to be dephosphorylated, will be more consistent, so that
I,
everyone
yeah.
gets the similar amount. Um,
Yes.
and if any of these things are true, then so oral psilocin could be maybe a better medication to use for treatment trials, right?
Yeah.
The idea is that if you have a more consistent, subjective effects with the dosage, and maybe the time course is more easily to manage, and maybe, I mean, the home run if the side effects are less, then that would be a whole bunch of reasons just to use psilocin instead of psilocybin and say depression.
Yeah, absolutely. I'm going to break down all those. You mentioned a lot of ways
Oh,
in which
sorry.
it.
Yeah.
No. This is exciting. You just
Yeah.
like laid out the groundwork here. So the perfect little roadmap for us to take. And I wanted to start with if you could just because you just said dephosphorylation. So if you could nerd out for a second and tell us exactly kind of like what the difference is, as much as you can, as much as you want to.
Yeah. Well, so I'm not a chemist, but my understanding is that psilocybin has this extra group on it. It has this um, phosphate group,
Okay.
and when you take it orally, there's an enzyme that removes that group and turns it into psilocin. So that's what psilocybin is, the prodrug of psilocin. So
Okay.
psilocybin turns into psilocin, and then psilocin is the thing that goes in your blood and makes you trip.
Does the effects.
Yeah.
Gotcha. And this happens in the stomach,
Yes.
that conversion.
Yes.
Okay.
And I think, yes, that's my understanding.
Okay. And how, when you're setting up this trial, because I know like when we talk about psilocybin, the mushrooms that's grown out of the ground versus synthetic versus maybe truffles, there are a lot of questions on dosing. What's an equivalent dose? So
Hmm.
when you're setting up these trials, are you giving the people the exact same dose of psilocybin and psilocin, or how did you factor that?
Yeah, we went with the same molecular, sort of the same number of molecules. So so
Molecular
psilocin
research.
is
Yes.
slightly smaller than psilocybin, so it's fewer milligrams, but based on the molecular structure, it should be the same number of molecules.
Okay, very cool. This is
Yeah,
bringing me back to organic
yeah.
chemistry,
It's been a
and I
while.
like
It's
it.
been a
I like
while.
it. Yeah.
Yeah. Um,
It has been a while.
It's been a while. There have been very few studies of psilocin. There was one study back in the 60s with I think it was IM, intramuscular injection of psilocin into prisoners against their will. So
Oof.
it was not a great thing, and it's a terrible thing. And the data was not that usable, but it has been done before. But there has been no studies of oral psilocin. So we tried to we tried to base it as best we could, assuming that all of the psilocybin was going to be was going to be metabolized into psilocin. So um, that we may be a little bit off. We may be, um, uh, yeah, we may be off, but it should get us in the right range.
Yeah, that makes a lot of sense. And let's talk about onset. Like,
Mhm.
tell us a little bit about what the psilocybin onset of action usually is, and what you guys think the onset of psilocybin, how that may differ, or a
Yeah,
psilocin.
psilocin. So oral psilocybin in the pill, it's typically it comes on in 90 minutes, and people have an experience over 8 hours, right? Uh, So, typically peaking at maybe 3 hours, 2 hours, something like that, and then coming down, and that's an advantage. That kind of time course, it allows people to use it in clinical trials for a single day, right? LSD, if it lasts like 24 hours, like how do you actually do that? Who's going to stay there the whole time? It's
Yeah.
hard to staff it. I mean, you could do it once, but like,
Right.
you have to hire people to do that. It's like it's not easy to work with. Um, we don't know with psilocin. I mean, the closest thing is lemon tech, which is a sort of
Yes.
underground thing that people do where they take their mushrooms and they dissolve them in lemon juice, basically. And turns out the acid can do the same conversion. And the reports are that when you do it that way, you get a faster, more intense high. But it's hard to know how many mushrooms went into it, and like we don't know. It could just be concentrating things from many mushrooms, but if you had taken that many mushrooms, you would get just as high but slower. So we don't really know. We don't really know. There's a chance that it'll be faster. I think is we think
Yeah,
not like
fast.
not like crazy fast, not like inhaled DMT because it's still oral, right?
Right.
But maybe instead of 90 minutes to come on, maybe it's 45. I mean, I don't know exactly. It's part of
Yeah.
why we're doing the study.
Right. And even that amount of change I think would be a clinical advantage.
It could be, yes. I mean, I think we're curious about that. I mean, we don't really understand anything about
Yeah.
the clinical, like, is it better to do it this way or that way? Like, I mean, what we do know is all from lore, which is important. People out there in the community have been figuring this out, indigenous communities, as well as underground practitioners. And this sort of psychosocial package, if you will, the therapeutic package has been kind of handed to us. And we do it this particular way. But a question about, like, how long the drug should last for. And I mean, and there are a lot of different traditions, right? I mean, ayahuasca versus LSD versus psilocybin, 5-MeO, and I think there are companies that are interested in inhaled or other deliveries for DMT, which it's like a 15-minute high. People talk about a business trip, and 5-MeO is even more intense probably. And like, we don't know, like, is that gonna work? Is that gonna be safe to work with? I think in the underground, people have different opinions. I'm not an expert in that, but is it better to have a short, intense high or a long, slow onset and downside? I think those are open questions. So if Psilocin is faster, that could be useful. It's possible that won't be useful. I don't know. For me, I think what definitely would be useful is if it was more consistent, right? Yeah.
Yes. Yeah,
So like if everyone had
absolutely.
the same sort of time course and we kind of knew it better, that would be good.
Right. Yeah, absolutely. I was just thinking that, like, if you're if you're in a therapeutic instance and you've got the therapist there and you're waiting 90 minutes for it to come on, as the patient, I can imagine, especially if the patient is doing it for, say, something like anxiety, that after a while they're going to think it didn't work,
Hmm.
and they're going to start getting more anxious. They're
That's
like,
certainly
"Oh, even
possible.
this doesn't
Yeah.
work,"
Yeah. Yeah.
and
Right.
because it is quite. I mean, it's a pretty variable and it's quite a long period of time. We're
That's
not
right.
used to something taking quite that long
Right.
necessarily in our day
And
to
so
day
maybe we
lives.
could cut that out. I guess I don't know. I think some of the therapists might say, well, though that's important time to get
Yes.
ready as it's
Right.
coming on,
Right.
right? And so,
Right.
I,
Pros and cons.
pros and cons. And I think psilocin is just one example of this along the spectrum, whereas DMT and 5-MeO are even farther along the spectrum, right? Like,
Right.
you don't like waiting? How about inhaled DMT? Like, so, and I think we'll see. And I imagine, I mean, I'm just speculating here, but I imagine that probably multiple of these medications will eventually be available, and people might choose. Like, consumers might be like, oh, I want a more slow onset, or I want to get this over with, or I don't know, different
Right.
ideas.
Well, I mean, I also think just for different therapeutic uses, like if you're going to do something where you're trying to work through PTSD, you don't want 15 minutes. You want that 8 hours with the MDMA therapy to work through it. So
Right.
I think that's what excites me about the future of psychedelic medicine is how many different forms are going to be available for different needs and different people's tastes,
Yeah.
right? Like you were
I
talking
think.
about the
Yeah.
Parkinson's community. And I know also that they're talking about different forms, for end of life. Well, maybe the end of life person doesn't want to go to some crazy DMT 15-minute like
Right.
terror ride. It might, as sometimes it
Yeah.
can
Right.
be,
Right. That's
you
what people
really,
describe it as.
right.
Yeah. One clinician I talked to said it was like learning how to drive on a Ferrari. So,
Basically good.
yeah.
I mean, it wholly depends on some people like have the greatest journeys of their lives and some it's difficult. But if you're at the
Right.
end of life, maybe something slightly more gentle with a more
Yeah.
gentle come on kind of thing
There
is
you go.
more. There
Exactly.
we go. There we
So,
go.
yeah.
Yeah. Well, that leads me into asking about, because you were talking about how it was given orally versus the other forms, but if it doesn't have to be broken down in the stomach, you said that opened up different.
Oh, yeah. So that's
Yeah.
another aspect of the study I haven't even talked about, which is so we're giving oral psilocin. It won't have to get metabolized in the stomach, but it would still have to be absorbed through the stomach. Um, but we're also doing sublingual psilocin. So
Oh.
sublingual, you can't do sublingual psilocybin because it won't get broken down easily, right? But sublingual psilocin, it doesn't need to be broken, it doesn't need to be metabolized, and it can go across your buccal membrane with skipping the gut. And that theoretically could be useful because then you might skip the first pass metabolism. It doesn't have to go to the liver, and it might be faster that way, and maybe again more consistent and fewer side effects. Maybe you won't get any GI side effects if it doesn't go to the GI tract, right?
Right, right. And let's break that down for people who are not quite aware.
Mm.
First pass metabolism. Describe how like that. I'm not telling you what to describe, but some people might
Yeah,
not
well,
know
I
that
think you
that.
know. I think you know. You're yeah.
I'm trying to break it down for the other people without just saying stuff. Like this is where this happens. But
Yeah,
tell us
right. So
about how the medication interactions
yeah.
generally.
So things that come from the gut the blood goes right to the liver, where the liver is sort of making sure that toxins and different things, and processing of glucose and stuff, and a lot of the breakdown of medications happens in the liver, and then it goes to the rest of the bloodstream. So sometimes if you give medications not through the gut, you can get a more consistent and faster onset because it kind of goes around the blood faster.
And also, generally, when you've got a medication interactions with like, if they're taking some other medication, a lot of times it's the enzymes in the liver that other drug and the
Right.
psychedelic drug are competing
That's right.
for.
They're
And
interacting. Yeah. Yeah.
yes,
Right. So
and so if it doesn't have to go to the liver,
right.
then
You
maybe
also might be more potent. Right.
it might be more potent and maybe fewer drug interactions if they're
That's
not
the
competing
hope.
for those enzymes.
Yeah,
Yeah,
that's the hope. I
cool.
mean, we won't know that from our study because the people won't be on other drugs, but
Right.
and we also we really don't know how much to give sublingually, right?
Yeah, that's
So
a big question
that's a
mark.
big question. So we're being very conservative with that, and everyone in the study will get both. Every time we dose them, they'll get a pill and a sublingual, um, film, so they won't know what they're getting when.
Oh, so one will be placebo and one will be active.
That's exactly right. And
Oh,
we're going to try and be looking for some signal about where we are in the dose range with the sublingual.
interesting. And so the same, and I'm sure this is the yes, but it had just not
Mm.
occurred to me till now. So that every healthy subject will at some point take both the psilocybin and the psilocin,
That's
so
right.
that you have
So
one.
within subject design.
Gotcha.
So
Very
right,
cool. Very cool.
because
And
yeah,
go ahead.
well, just within subject designs, you know, it's an interesting thing. I mean, talk about nerding out here. Within subject design, like why do we do that? Well, because everyone acts as their own control, right? So maybe one person responds to psychedelics a particular way, but they're going to get all the different ones that we're testing, so we can compare them. So it's a nice design in that way. Within subject designs, the problem with them is that people might be permanently changed. So
Oh,
like in
yes.
the Hopkins cancer trials, those were actually within subject designs, and the problem was that if you got the high dose psilocybin first, the people were better even when they went to cross over, right?
Ah,
So that
yes.
so there are downsides to within subject design, but in this case, we're not trying to change anyone. It's not about permanent change. It's just about like how high they get and their blood pressure changes, right? And we don't
Yes.
think those will change if we separate it out by a month. So, if we dosed really quickly, then there would be tolerance and tachyphylaxis, but we don't think that's going to happen at the kind of time frame that we're using.
Yeah, gotcha. I love that you bring up tolerance because I think it's something we don't talk enough about. If you could touch on it, and you can just tell me no if you don't touch on
Hmm.
anything, but if you could touch a little bit on how, because it's one of the big things that, in the medical community, people come to me and say, like, aren't these addictive? Everybody
Hmm.
who was raised on just say no is so afraid they're addictive. And
Right.
and I think that we kind of, and there are a lot of people who are doing microdosing things every single day or different
Right.
setups. Maybe they're doing a real journey all the time. And at some point, the psilocybin is going to stop working. Tolerance is going to develop. Can you speak to
That's right.
just a little bit to that?
Yeah, sure. I mean, we don't usually study that. Like we try not to do that. But my understanding from the literature is that if you take a high dose of a psychedelic, you know, every day, you
Yeah.
you quickly stop having psychedelic effects, right? And then
Yeah.
you have to wait a while for I don't. It's not clear. Maybe your receptors to come back up or something for the psychedelic to work again.
Yeah.
Um, and so that's my understanding of how that works. Tolerance, though, is a separate question from dependence or addiction, right?
Yes.
Tolerance is just you take a medication and then you might need a higher dose, right? That's the tolerance. And this happens with all sorts of things. It doesn't mean you're addicted to it. It just means, your system has adjusted to it.
Yeah.
Dependence or addiction is when you start escalating your dose and becoming more and more focused on getting the drug, right? Or
Yes.
behavior, if you will. And so, the classic would be IV heroin, right? People use IV heroin and then they spend more and more time trying to get IV heroin and it takes over their entire life and that's all they focus on, right? That's a
Yeah.
classic example of dependence. Or the alcoholic, right? The alcoholic drinks and then starts having more and more problems that get in the way of their work and their relationships, and yet they keep drinking. That's another
Yeah.
definition of it, is sort of continued use in the face of adverse,
Yes.
outcomes.
Yes. Well,
With that definition, people don't really get addicted to psychedelics. Like people don't escalate their dose or become really focused on getting more and more of it and sort of using more and more. That isn't really the pattern of use. It's exceedingly rare.
yeah.
Most people who use it at the high dose, they're happy to use it infrequently, right?
Yeah. Yeah.
Because it's not.
And if
Yeah,
they don't, it stops working.
that's right. And if
Yeah.
they don't, it stops working. Um, so yeah,
Yeah.
and microdosing. You brought that up. We haven't done any trials of microdosing, and actually, no one has really. There are some trials that are starting up now, and there have been some citizen science
Right.
studies where people have been in, like basically looped in, and it's actually very clever. They actually got the people's drugs and then randomized their own drugs to whether or not they got placebo or
Yeah.
microdose
That
of.
was a
It's
nice
pretty
design.
right, but those studies found that actually it only mattered if you thought you were getting psychedelics. So that kind of suggests that maybe it isn't about the drug effects, but I would say that the data is really not in yet.
Yeah. Lots of questions there.
Yeah.
You had brought up, you touched on the blood pressure and the different physiologic effects. Can you talk a little bit about what physiologic effects psilocybin tends to have on users?
So in our trials or other people's trials, when you give a high dose of psilocybin, and just for it's a lot of people ask me like, well, how much psilocybin are you giving? So we and other groups typically give about 25 milligrams of synthetic or pure psilocybin. It's not clear exactly what that translates into in mushrooms because mushrooms are highly variable, right?
Yeah.
Each mushroom can, vary by, I think it's a factor of 5 or 10 in their psilocybin content. And so, that's what leads to the dreaded underdose and, other things that people,
The dreaded underdose.
yeah, that people don't know. They don't know how much to take because it changes every time with each batch and even individual mushrooms within a batch. And that's why there haven't been any clinical trials of using mushrooms because it's too variable to use. But I can tell you that a 25 milligrams of pure, synthetic psilocybin is an intense trip. People are, have a full mystical experience typically. They're incapacitated. Many people say this is way more than I've experienced out in the world.
Oh.
I'm sorry, and what was your
Oh,
question?
the
What
question
are
was
the
physiologic
physiological?
effects.
Yeah, so the most common one, and this is almost everyone has this, is increases in blood pressure and heart rate. And so that's a major issue in that we can't dose people who have high blood pressure because it's too dangerous.
Okay.
And out in the world, people do this, and a lot of people have high blood pressure. I mean, it's a silent killer. And so I wonder about that, especially as these drugs become more widespread and people are using higher doses of them in sort of semi-regulated treatment contexts. But in our trials where we give this high dose, we have to make sure that people don't get too too hypertensive.
Yeah.
Because that can be very dangerous, of course.
Yeah.
And then that's the main one. That's the main thing we look for.
Yeah.
People will also have, can have headaches or anxiety or some GI things. Those are pretty common, but they're, not so severe, and they are typically self-limited. They go away.
Yeah, let's talk about those GI things, because
Yeah,
I think those are. It's funny because some people, it's just so obvious they know this is a thing, and then it's funny. I'll mention to some other people. They're like, people get nauseous on mushrooms.
yeah,
Yes.
yeah.
So let's talk a little bit about some of the hypotheses for why, because I've heard maybe like one or two. Is it the serotonin receptors in the gut, or is it just maybe that metabolism from psilocybin to psilocin? Can you talk a little bit about some of the things?
I don't know. I mean, I I think I mean I've heard a lot of different theories. Serotonin in the gut, serotonin in the I think the area postrema. That's the part of the brain that is important for regulating nausea, like for like toxins. Then it's serotonergically innervated, right? So it's this. It could just be the serotonin signaling that's telling your brain, oh, we have a toxin, and you get nauseous because of that.
Oh,
Um, I don't think it's been well worked out. It's not clear, and that's why we're not totally sure that psilocin will have less GI subs. Because if it's at some sort of central thing, it's going to
yeah,
affect that too. But if it's something in the gut, then we're hoping the sublingual will bypass that. All right.
yeah.
So we don't know. Um, but it is an issue. People, it's not great. People don't
It's
love
it,
that.
people don't love that because I think that was one of the biggest side effects in the Compass results just came out,
Yeah.
and I think that was the number one side effect mentioned.
Oh, did they say what percentage? I didn't see that.
I don't recall. Maybe it's just that it's the one that I'm so aware of that it jumped out to me.
Yeah,
But
but it is a very common side effect that
yeah,
people have. Um, so if we could bypass that, that could be nice for people.
yeah, yeah, absolutely. And can you talk a little bit about why you think perhaps, and we touched on this a number of times, but why perhaps psilocin might be more consistent than other things? Is it based on the fact that the individual's metabolism is no longer
That's right. That's
part
exactly
of it?
that's our hypothesis, and that oral psilocybin. There are probably multiple steps in the gut, and you know, but this metabolism might be an important one. That there could be variations between people and how efficient those enzymes are, and so that would, how fast things get metabolized could affect, how much psilocin you get in your blood. That's the idea.
Yeah. Yeah.
And so if we skip that, maybe people would have a more consistent effect.
Is there any, because you're going to do the oral version and then you're
Mm,
going to do the sublingual, is there any talk of doing something, because even sublingual, I'm assuming that there might be enzymes in the mouth that differ person to
totally.
person.
Yeah. And so it's possible. We're not going to take one person and give them oral psilocin over and over again. So we won't know like how variable it is within the
Right.
person. Um, but everyone is going to get the same doses. So, we're hoping that everyone will get similar effects. The study wasn't powered to detect that specific thing. It's really powered to detect time course and intensity, right? Because like if it's way more intense, that could be a problem, right? Like we would have to give
Yeah.
less, right?
Right.
We don't think it's going to be way more intense, but it's certainly a possibility. And in the time course in the cardiac, the blood pressure has a pretty typical curve, and so we're hoping that we'll really get a sense of that. Um, and of course, we're going to look at the side effects, and we're going to look at how consistent it is between people, like in these measures. But we're not measuring blood levels. We decided not to do that in this first study because that's pretty involved, right?
Yeah.
Take
Because
because to do it right,
yeah.
you'd have to have an IV in, and you'd want to take
Right.
blood like every 15 minutes or every 20 while the person's on a high dose psychedelic. It's not
Yikes.
it's not great, you know.
Right. It's not great. You need one of those things like the continuous glucose monitor kind of thing
Yeah, yeah,
for.
you'd want that. I mean, they did do this at Wisconsin. They have a very elegant study. Um, but it takes like the level of care. They're basically in a hospital with nursing, and it's like a whole thing. So we decided not to do that for this first study.
Yeah, because what I was gonna ask is like, is the way that would be have the least number of variables to do something intravenous or intramuscular?
Oh, probably, yes. I mean, and but it's just not that practical,
Yeah.
right? I mean, people
And
have done IV psilocybin. There's a study or two with that. It was a neuroimaging study, so it wasn't a
yes.
therapeutic study.
Right.
Um, and they did that just because they wanted to control the high in the scanner, right?
Right.
And it works. I mean, people people
It works.
have a trip. But IVs, who's going to put the IV in? It's like a whole thing.
Right. Right.
So we don't really want to go down that path. And IM injections, that's another thing. Like people don't love that to
Right.
be
Right.
injected.
Absolutely.
Yeah.
Well, that does bring, I mean, that gives us a lot to think about with different, the different forms and different applications coming out. So if we've got any budding scientists listening that are, putting together some creative thoughts about studies, thank you for elucidating all of that. Can you tell us a little bit about, because I know you're Tripper,
Mm.
cutest name ever. I don't, it's funny on so many levels. I just love it. It's just, it's cute and it's funny and it actually stands for things. Can you tell us a little bit about more some of the exciting the studies that you all
Mm.
are involved in that are
Yeah,
coming
that we're
out,
excited
or
about. Yeah,
yeah,
sure.
that you're excited
Well, I already
about?
told you about our Parkinson's study, which,
Yes.
as I said, we're dosing someone hopefully next week, and as I said, we're hoping to both decrease depressive symptoms, help people adjust, sort of existentially to their situation, um, and there is a possibility that it could help with some of the motor symptoms or cognitive symptoms. That's pretty speculative, but we're gonna look mostly to make sure it's safe. But if it improved those things, we would be very thrilled.
Yeah.
There are some animal work to suggest that it can be neuroplastic and neurogenesis. And so we're doing that study. Another study that we're really excited about is psilocybin for depression in people with bipolar 2. So that's another
Ooh.
study. So we're going to be starting recruitment for that in 2022, early 2022. And as you probably know, there are a lot of trials of psilocybin for unipolar depression,
Yeah.
right? The Compass trial, like you mentioned, that's TRD, so that's treatment-resistant unipolar depression, that show promising effects. But anyone with a history of bipolar, or even family histories of bipolar, so first-degree relatives, some studies even do second-degree relatives, like that's like your cousin. Like if you have a cousin, you
Right.
couldn't be in one of these studies, which seemed excessive to us, but there really isn't any data. There's very little data about that. There's lore that people with bipolar can be made worse, and so we actually have done a couple things. We first did a review of all the case reports that are published, looking for any evidence of worsening of bipolar symptoms or in people with bipolar who had a bad outcome. And we did find cases there. We found 17 cases of people who basically seemed like either the psychedelic had induced a sort of manic state, or they had bipolar and it induced a worsening of their bipolar illness, sort of a depression or something. Now, most of those cases involved other drugs or using simultaneously, like a psychedelic plus cocaine or psychedelic. They also often involved using psychedelics many times, like you're saying. So in these clinical trials, we do once, but
Yeah.
like if you use it like every couple days for 3 months, that's probably a very different experience. Um, and none of them involved any of the holding environment, the set and setting, the therapists that we think
Yeah.
are so important to keep people safe through the journey. So they're people doing this all on their own, which is always a riskier situation. But it does seem like it is possible that psychedelics can make symptoms of bipolar worse. We followed up that case report review with a international survey. So we did a survey where we asked people, do you have bipolar and have you used psilocybin containing mushrooms or psilocybin? And then we asked them what happened. And this data isn't published yet, but basically we found that about a third of people said that they developed a new or worsening symptoms over the 14 days after they used a psychedelic. This include depression, mania, or insomnia. And that about 3% of people actually ended up in the hospital or had some interaction with the medical system. But when we asked them about the harms and the benefits, the vast majority of people said the harms were minimal and the benefits were very high.
Wow.
So,
Okay.
this is sort of this tension, right? Where people with bipolar, now these are people out in the world just using psychedelics, psilocybin in particular, who know they have bipolar. People say it helps them. They find it very valuable. It sometimes helps them with their symptoms, but sometimes it makes their symptoms worse, and sometimes they're very bad outcomes. So that gives us pause, but also makes us think, well, these people are not using it in the way that we do it in the trials, right? A consistent dose, well screened, all this framework. But it also makes us think that there is some risk. And so we're going to do a trial. We're doing a trial where we're actually going to take people with bipolar 2 who are depressed and treat them with psilocybin, mostly focus on safety. Like, will people become manic? We hope not, but we're prepared if they do. And
Yeah.
can we help
Yeah.
them with their depression? Which
Yeah.
I don't know if I said, but bipolar depression, the treatments are not great.
Right.
Right? We don't have
Right.
very effective treatments. A lot of people give up on pharmacology because the side effects are high and the treatments are not great. So if psilocybin could be a treatment for bipolar depression, that could be a really useful, positive thing. So we're doing that study, and then another study that I'm really excited about, which is starting probably in March. And this is a study that's in collaboration with Boris Heifetz at Stanford and Michael Silver at Berkeley. So it's a 3-institute effort. We're doing a study of psilocybin for chronic low back pain.
Oh, wow.
Yeah. So, there have been hints that psychedelics can be helpful for chronic pain. People out in the community talk about it. There was just a study that came from the Imperial group that was I think it was a survey. It was some interaction with the community, and people were saying what they had used psychedelics for with their pain. And there have been a couple of studies in healthy people showing that it can be psychedelics can be an analgesic, so actually decreasing the intensity of pain short term. And so we think that psychedelics, psilocybin in particular, might be able to change people's relationship to their pain. It might be an analgesic too. It might make the pain go away. That would be great. But even if it doesn't do that, we think that it should allow people to, basically find the pain less impairing, right?
Yeah.
Like a lot of modern psychotherapies around chronic pain are about accepting the pain, right? Sort of. Obviously, we do everything we can to get the pain to go away. We try and treat the pain, we do the treatments, but sometimes those don't work. And then what do? Well, you try to accept the pain and live your life anyway. And that's really hard for people. It's hard for me. And yet we think that psychedelics might help people do that. Kind of like no one thought that psilocybin was going to cure the cancer in those cancer trials.
Right.
Right. Right. Like that wasn't the goal. Right. The people were still at risk of dying of cancer, and many of them did. But it was about changing their relationship to it. That it wasn't as existentially horrible. Right.
Yeah.
It was more, this is part of the cycle of life, perhaps, or each person had their own sort of way of coming to terms with it, but feeling alive anyway. I mean, we're all dying, right? So, we don't like to think about it, but I think, being okay with how things actually are, I think is really important. And maybe psychedelics can help people who have these chronic pain conditions.
Yeah, absolutely. I'm very excited about both of those. Are those currently enrolling?
No, but they will both be enrolling in the first half of 2022.
Okay, great. So clinicaltrials.gov, anybody who is interested.
Or you can check out our website, psychedelics.ucsf.edu.
There you go. Get that plug in.
Yeah.
I was going to ask where people should go.
Yeah.
Psychedelics.ucsf.edu.
That's right.
Excellent. If you want to be in with the Tripper gang and participate in one of their studies. I am fascinated. Josh, will you come back on and tell us the results of those studies?
I will, yes. Unfortunately, it takes a long time. These things are, they're not, it's not fast.
Well, I won't put it on the calendar today, but
well, we're working as hard as we can. We're going as fast as we can, because we're excited to understand this and see if it helps, because these compounds are I'm pretty confident they're going to be rescheduled in the next couple of years, and we want to know who it can be helpful for and how, and who it is actually not helpful for. Like, is it really not safe to give to people with bipolar? Like, that's important to know too, right?
Yeah. That's a fascinating study that I'm so glad you guys are doing.
Thank you.
So yeah, I'm sure many listeners will be looking forward to the update on that one, and maybe looking forward to when you start enrolling for those trials, because absolutely, like you said, for anything that the treatments have been fairly ineffective is, a lot of people hurting and ready to get some real relief.
I know. And I mean, that is really my motivation for getting into this space. We all have our own reasons, but for me, I'm a biological psychiatrist. I was studying other treatments before, and they're just insufficiently effective, right? And you say, like, oh, the treatment, the conditions that we don't have good treatments for. In in neuropsychiatric disorders, that's almost almost
Yeah,
everything. We have
most
some that
everything.
we have like better treatments for that are like less terrible, and then we have some that we like really don't have any. It's like like barely adequate to like totally inadequate. Those are our options, you know.
Right.
Um, and so, I really, I am hopeful that this can, sort of transform how we do things. I think there's a lot of research that needs to be done, and I think there are risks involved in these things we need to know. But the signals have been very large, and so I'm excited about it.
Well, I'm excited with you, and I appreciate you coming on to share that with us. And thank you for the work that you are doing. And you've already given your plug. So, again, everybody go to psychedelics.ucsf.edu or in the early 2020 clinicaltrials.gov to participate. Josh Woolley, thank you so much for coming on the show and sharing with us today.
My pleasure. My pleasure. Thank you.
Absolutely. For everyone else out there, until next time. Thanks so much for listening to the Plant Medicine Podcast. If you enjoyed what you heard, please leave us an iTunes rating or review. It helps other people find the show. And if you'd like to find out more about plant medicine, including the show notes from today's episode, please head over to plantmedicine.org. The music for the Plant Medicine Podcast is by the incredible Porangi. If you'd like to check out his music, please find him at porangi.com or on social media at PORANGUI.